Assalamu alaikum. Today we will continue discussing the family Nesriaceae. Before we start, in the previous lectures we talked about the classification of bacteria according to their shape into cocci, bacilli, and coccobacilli. And according to their gram stain, we classified the cocci into gram positive and gram negative. The gram positive bacteria, we have staphylococci, and we classified them according to the pathogenicity or coagulase production into coagulase positive, which includes the Staphylococcus aureus, and coagulase negative Staphylococci, which includes the other genera, Staphylococcus epidermidis, Saprophyticus, and so on. Also, the other gram-positive cocci, we talked about the Streptococci, and they are also classified according to their hemolytic pattern into alpha, beta, gamma, or according to the Lansfield grouping into group A, B, D, and so on. In the previous lecture, we talked about the family Neisseria. We mentioned that the family Neisseria are gram-negative bacilli, which includes many genera, including family Neisseria includes many genera, including Kingella, Echinella, Neisseria, and more than 32 species. Regarding the Neisseria species, we have non-pathogenic species which are present as a normal flora in the mucous membrane of the upper respiratory tract, and we have two pathogenic species, Neisseria gonorrhea and Neisseria meningitidis. These are the important two pathogenic species. We talked about Neisseria gonorrhea. Neisseria gonorrhea causes, from the name, gonorrhea, which is a sexually transmitted disease. It causes acute pyogenic infections. In males, 95% are symptomatic. It causes pyogenic infection and affect the urethra, and the infection may be ascending, causing orchitis, epididymitis, and later on might cause strictures and sterility. In females, 50% are symptomatic. It causes infection in the endocervical area, not the vagina, in the endocervix, and the infection may ascend upward, causing salpingitis, endometritis, and pelvic inflammatory diseases. Also, it may lead to perihepatitis. In a newborn baby, it may cause ophthalmia neonatorum, which is infection of the eye. The diagnosis of infection with Neisseria gonorrhea: first, slide a gram stain of the smear. We will see gram negative diplococci intracellular, which is very important differentiation point between the pathogenic and the non-pathogenic species. Gram-negative diplococci could be present intra and extracellular. The non-pathogenic species present only extracellularly. The second step is the culture in the diagnosis. Usually, the family Neisseria, the pathogenic species Neisseria gonorrhea and Neisseria meningitidis are fastidious, which means they need enriched media for their growth. Enriched media with CO2 and humidity All these things should be available for the cultivation of Neisseria gonorrhea. The selective culture media used are Thyre-Martin agar, modified Thyre-Martin agar, Gonococcus lectine agar, and New York City agar. All these are selective culture media. The first three are chocolate agars, and antibiotics and antifungal agents are added to make these media selective for the cultivation of the microorganism. So we first use slide gram stain of the direct smear culture. The third step is the biochemical reactions for the diagnosis of Neisseria gonorrhea. Neisseria gonorrhea oxidase positive, catalase positive, and glucose utilization positive. And we also mentioned that Neisseria gonorrhea contains in the cell wall many virulence factors that are important in the pathogenicity and virulence of the microorganism, which are the lipo-oligosaccharides, pili, outer membrane proteins, IgA protease, beta-lactamase, and the plasmid. The important point, which is a differentiation point, one of the differences between Neisseria gonorrhea and Neisseria meningitis is that when there is infection with Neisseria gonorrhea, there will be no immunity to reinfection. Once there is infection, there will be no formation of antibodies, so recurrent infections could be occurred. And when we treat Neisseria gonorrhea, we use ceftriaxone, and sometimes there is coexistence of chlamydial infection, so we use another antibiotic, which is azithromycin, for the treatment of concomitant infection of chlamydia. So morphologically, the genus Neisseria, all the species have the same macroscopical appearance. They are all gram-negative cocci, 0.8 micrometer in diameter, occur in pairs with adjacent flat side, giving them coffee bean appearance. They inhabit the mucous membrane of humans, and they are non-motile, non-spore forming, catalase positive, capnophilic, and grow in moist environment. They are all oxidase positive, catalase positive. Most Neisseria species, as we mentioned, in humans are normal inhabitants of the upper respiratory tract and are not considered as pathogens. And Neisseria gonorrhea always considered as a pathogen, regardless the site of isolation. This point mentioned in the previous lecture. Always Neisseria gonorrhea, when isolated, considered as a pathogen, never considered as a normal flora. Neisseria meningitis, although it may cause severe diseases, it may colonize the human nasopharynx without causing disease. So sometimes considered as present as flora in carrier persons. And we mentioned also that Neisseria gonorrhea is more nutritionally demanding than Neisseria meningitis. Neisseria meningitis and Neisseria gonorrhea primary human pathogens and are intracellular, while the non-pathogenic species are extracellular, present in the extracellular part in the smear when we examine it under the microscope. There is a non-pathogenic species, which includes Neisseria cinerea, Neisseria flavescens, lactamica, mucosa, and polysaccharia. The pathogenic species, we mentioned that they are Neisseria gonorrhea and biochemical reactions in Neisseria gonorrhea, like all other groups in the genus Neisseria, they are catalase and oxidase positive. The important differentiation point between gonococci and meningococci is the sugar utilization. Meningococci utilize glucose and maltose, while Gonococcus or Neisseria gonorrhea utilizes glucose only with the production of acid and no gas. And there is no lactose or sucrose utilization. Only glucose and maltose utilized by Neisseria meningitidis, while Neisseria gonorrhea utilizes glucose only. Like the gonococcus, Neisseria meningitidis contains also many virulence factors, including the capsular polysaccharide, and there are 13 different capsular polysaccharides. The most important in the epidemics are type A, B, C, Y, and W135. Capsule is an important virulence factor because it renders the microorganism resistant to phagocytosis and enhances the survival of the microorganism during bloodstream invasion inside the polymorphonuclear leukocytes. Also aids in the CNS invasion. The other important factor in the virulence is the pili, which mediates the attachment of the microorganism to the epithelial lining of the nasopharynx. The third virulence factor is the outer membrane protein, pore A and pore B. In Neisseria gonorrhea, there is only pore B. There is other outer membrane proteins like OPA and OPC proteins which facilitate adherence to the different cells and mucosal adherence and invasion of endothelial cells. Iron binding protein, lipo-oligosaccharide like gonococcus, IgA protease, plasmid are all other common virulence factors. Plasmid uncommon in Neisseria meningitidis. However, beta-lactamases encoding plasmid from gonococcus can be transferred to Neisseria meningitidis. Meningococci are very delicate organisms, being highly susceptible to heat, desiccation, alteration in pH, and to disinfection. They die within a few days at room temperature, and they are killed by heating at 55 degrees in 5 minutes. This is a gram-stained smear, direct smear, showing that the gram-negative diplococci are present inside these phagocytic cells. So they are present intracellularly. The pathogenic species present inside the polymorphonuclear leukocytes. This smear is prepared from culture. This slide prepared from culture. The previous slide, direct smear. When we see these cells, this means that this is a direct smear. While this slide is prepared from culture. We see only the gram-negative diplococci, and there is no cells because the slide is prepared from culture. We will see the gram-negative diplococci kidney-shaped or coffee bean appearance. Neisseria meningitidis is a primary pathogen of a human. It may cause infections from occult sepsis with rapid recovery to a fatal disease. It's highly contagious and transmitted by respiratory secretions. Humans are the only natural host for whom meningococci are pathogenic. The nasopharynx, so will be the portal of entry because they are transmitted by droplets, and they are, the organism attached to the epithelial cells with the aid of pili, and they may form part of the transient flora without producing symptoms. From the nasopharynx, organism may reach the bloodstream producing bacteremia, and the symptoms may be like those of an upper respiratory tract of infection. So that disease is contagious by respiratory secretions or droplets, and the portal of entry is also the nasopharynx. The microorganism will reach the nasopharynx. It will be attached to the epithelial cells by the aid of the pili, proliferate, and may cause invasion to the blood, bacteremia, and other symptoms. It may cause fulminant meningococcemia, which is more severe, high fever, hemorrhagic rash, and there will be disseminated intravascular coagulation with circulatory collapse. So there will be either bacteremia, meningitis, which is a most common complication of meningococcemia, and it usually begins suddenly with intense headache, vomiting, and stiff neck, and progresses to coma within few hours. During meningococcemia, there is a thrombosis of many small blood vessels in many organs, with the perivascular infiltration and petechial hemorrhage. They may be interstitial myocarditis, arthritis, and skin lesions. In meningitis, from the name, meningitis means that the meninges are acutely inflamed with thrombosis of blood vessels and exudation of polymorphonuclear leukocytes, so that the surface of the brain is covered with a thick, purulent exudate. From a CSF smear, we will see that there will be intracellular leukocytes. The importance of meningococcal disease is that it may cause outbreaks in overcrowded areas like prisons, military, schools, and so on. So in the Middle East, most meningococcal disease is associated with Hajj to Mecca. In 1987, an outbreak caused by serogroup A, as we mentioned, that Neisseria meningitis contain a polysaccharide capsule, and according to this polysaccharide capsule, there is 13 serogroup A, B, and so on. The serogroup A is responsible for the outbreak which occurred in Mecca in 1987. After that, meningococcal A polysaccharide vaccine was made mandatory in order to enter the Saudi Arabia. This resulted in disappearance of this strain in that area. In 2000, the serogroup W135 emerged during Hajj, causing 400 cases of meningococcal disease. So the subsequent introduction of quadrivalent meningococcal vaccine into Saudi Arabia is a visa requirement for Hajj participants and has eliminated the outbreak in the region. So it's important cause of an outbreak in overcrowded areas. An important thing is that some people are carriers to meningococcus. As we mentioned, the microorganism may be present in the upper respiratory tract without causing disease. Why these people are not affected with meningitis? Why did a microorganism not cause infection in these people? This is because that the meningococcal colonization of the upper respiratory tract may cause humoral immune response with formation of serogroup specific antibody within 7 to 10 days, which will not eliminate the carriage state, but may protect the host from over disease, mean the microorganism will stay in the upper respiratory tract, will not be eliminated by this antibody, but it will prevent invasion of the microorganism inside the body. Or the other theory is that there is a clonal analysis, mean that there is avirulent clones are found in asymptomatic carriers, which rarely cause disease, while the virulent clones have high transmission rate and cause high rate of disease in patients. And these clones may disappear and reemerge. So, how we can diagnose infection with Neisseria meningitis? First, a specimen, which includes either CSF in case of symptoms of meningitis, blood in symptoms of bacteremia, nasopharyngeal swab, and this swab is cultivated and incubated under CO2 like gonococcus and humid condition. Gram stain of cytocentrifuge CSF, we will see intracellular gram-negative diplococci. After smear, and like the gonococcus, the smear should be transferred to the lab using transport media to prevent dryness and death of the microorganism in the swab, or should be directly inoculated on the culture once taken from the patient. Culture media used, we use selective culture media and non-selective culture media. Both should be enriched culture media. Sheepy blood agar or chocolate agar plated on chocolate agar and incubated at 37 degrees in an atmosphere of 5% CO2 in candle jar. Freshly drawn spinal fluid can be directly incubated at 37 degrees. The other selective media modified Thark-Martin agar with antibiotics, vancomycin, colistin, and amphotericin, favors the growth of Neisseria. It may inhibit other bacteria and fungi. Oxidase positive like other Neisseria species, catalase positive like other Neisseria species, and carbohydrate utilization in Neisseria gonorrhea utilizes glucose, while in this case, in Neisseria meningitis, it utilizes glucose and maltose. Glucose and maltose in Neisseria meningitis. The other method of diagnosis is using latex agglutination to detect group-specific surface antigen of Neisseria meningitis, but they don't replace the gram stain or culture. The molecular methods are available but not present commercially. This is the slide with a gram stain of the direct smear. When we see these cells, means this is direct smear. Intracellular microorganism present inside the polymorphonuclear leukocyte. This is the cell, and this is the intracellular microorganism. And there may be also extracellular diplococci. This is the modified Thayer-Martin agar, which is a chocolate agar supplemented with antibiotics and antifungal. We will see small colonies, circular, and slightly yellow in color. This is the sugar utilization test. Neisseria meningitis utilizes glucose and maltose, but not lactose or sucrose. Positive glucose, positive maltose, negative lactose, and negative sucrose. When we see this yellow color, means this is a positive sugar utilization test. This is a sugar utilization test of Neisseria meningitis and Neisseria gonorrhea. In Neisseria meningitis, glucose and maltose utilized, while in Neisseria gonorrhea, glucose only utilized. Treatment. The drug of choice for the treatment of Neisseria meningitis is penicillin, but rifampicin or sulfonamide recommended as a prophylaxis for close contact. The patient with meningococcemia is best treated with third-generation cephalosporins. In Neisseria gonorrhea, in the previous lecture, we mentioned that there is no immunity to reinfection, so there is no vaccine because of the antigenic variation of the antigen of the pili and outer membrane proteins and polysaccharides. So there is no immunity and no vaccine produced to Neisseria gonorrhea. While in Neisseria meningitis, there is a vaccine which is called the quadrivalent vaccine, contain polysaccharide antigens to serogroups A, C, Y, and W135, which is the most common serogroups causing epidemics of meningitis. It's conjugated with diphtheria toxoid protein. This conjugate vaccine is expected to provide long-term immunity. The vaccine doesn't protect from infections caused by group B, because group B polysaccharide is poor immunogen in a human, so there will be no production of antibodies against this polysaccharide capsule. So there is no immunity to type B serogroup of meningococcus disease. It is recommended to be given to students 11 to 12 years of age, those entering high school, military recruits, asthmatic patients, travelers to area of epidemics, and laboratory personnel. Whenever there is crowding areas or dealing with samples containing this microorganism, the quadrivalent vaccine is recommended. Why asthmatic patients need meningococcal vaccine? Because the spleen is an important clearance of the microorganism early in the course of any infection with capsulated microorganism, before antibody production is fully established. So the spleen has an important role in the host response to encapsulated microorganism. Splenectomy will lead to loss of most of the important filter of encapsulated microorganism. Spleen is important filter of this microorganism, and in splenectomy patient there is a decreased immune response to polysaccharide antigen. Also, the vaccine not administered to children less than 2 years, administered to children older than 2 years. Why? Because the younger age group don't respond to polysaccharide antigen. So there will be no production of antibodies to this antigen, and the vaccine will not be benefiting them. The immunity is group specific, which means when we vaccinate patient with serogroups ACYW135, the immunity only to these serogroups, and the person will not be immune to other serogroups. We mentioned that there's 13 serogroup of meningococcal bacteria. The other Neisseria species, which are commensals and present normally as a normal flora in the upper respiratory tract, example of them, Neisseria lactamica, which is very rarely causes disease, but is important because it grows in the selective media. When it grows in the selective media, we may mistake Neisseria lactamica from the with the pathogenic species because it grows on the selective media, like modified Tire-Martin medium, used for cultivation of gonococci and meningococci. So can be cultured from the nasopharynx in people, 3 to 40% of persons, and most often is found in children. And unlike the other Neisseria, we can differentiate Neisseria lactamica from Neisseria meningitis and Neisseria gonorrhea by the lactose utilization. Neisseria gonorrhea utilizes glucose only. Neisseria meningitis utilizes glucose and maltose, while Neisseria lactamica utilizes glucose, maltose, and lactose. The other gram-negative bacteria, gram-negative cocci, is Moraxella cataralis, which is mistaken with the genus Neisseria. They are morphologically gram-negative cocci, not diplococci, only gram-negative cocci, present singly. They are non-capsulated, non-motile, and they are aerobic, grow on nutrient agar, blood agar, or chocolate agar. Moraxella cataralis is oxidase positive, catalase positive like Neisseria, but it doesn't produce acid from glucose, which is an important differentiation point between Moraxella and the family Neisseriaceae. It not utilizes glucose, maltose, sucrose, lactose, or fructose. And the other test in the biochemical reaction is the reduction of nitrate to nitrite. This is Moraxella cataralis. It is part of the normal pharyngeal flora. It not cause infections, but can cause respiratory infections, simple infections like otitis media, sinusitis, tracheobronchitis, and pneumonia. Most strains of Marxella catarrhalis from clinically significant infections produce beta-lactamase, which render the microorganism resistant to penicillins. Thank you.